Good afternoon. My name is Ken Serota, and I'm here visiting with Jorge Wong in Mexico City. He's asked that I do a presentation on access this afternoon. So to give you a sense of my background, which entitles me to do this, I graduated from the University of Toronto in 1973 and from endodontics at Harvard in 1981. Throughout my career, I have been fascinated by online education. In 2000, Dr. Joe Dovgin and Fred Barnett and myself started an online forum called Roots. We ultimately were able to provide Roots summits on an annual basis with the support of manufacturers throughout the world. In 2015, I initiated an online program forum called Nexus. It's on Facebook. The advantage that it had was it was able to bring all of the specialty disciplines together and to coalesce. And specifically in endodontics, it was prescient, because in the last, say, 5 years, endodontics has become orifice and restoratively driven. We are focused now on preserving pericervical dentin and certainly any residual coronal tooth structure possible. So in regard to, we're going to move the slide ahead, Jorge. The slide that I'm going to show you is a slide that was a micro CT that was done by Dr. Ronald Ordonolo Zapata, who I think has just recently graduated from Einstein in Philadelphia. The beauty of finally being able to see axial slices is that for the first time you were able to recognize.
Wait.
What's going on?
I think it didn't go live directly. I think I'm gonna start again because. Yeah, let's keep on. Just keep on. Okay.
You don't want to start? Okay. All right. Okay.
We had some technical issues.
Technical difficulties. The slide that's up at the moment. We okay? We're good? The slide is showing a micro CT done by Dr. Ronald Ordonolo Zapata. Recently graduated from Einstein. He's done some remarkable work with computer reconstruction of the pulp canal space, similar to what Dr. Versiani is doing, and very much now being propagated by Diego Guerrera. The next slide will show what we are currently addressing in terms of endodontics. There is a dramatic change and a shift from what was considered traditional endodontic cavities or preparations to what is increasingly more conservative and even to the point of being minimal, which is the somewhat euphemistically called ninja. You can appreciate on the slide on the right that particular slide is reflective of the changes that have gone on with respect to what we were able to evaluate. The traditional outline is the dotted line. That is a little difficult to see. But what you were, I got to stop, Jorge, I'm sorry. I blew it. Yeah, okay, so, all right, we're not stopping. So what you're looking at on the left slide is a conservative endodontic access in the maxillary molar. So the occlusal view demonstrates, by comparison, what a traditional endodontic cavity preparation would be like. That's outlined in the dotted line. So you can appreciate the difference in terms of the magnitude of tooth structure and the coronal structure, the crown in this particular case that has been removed. The view to the right is of a reconstructed micro CT, a 3D of a tooth, where the root canal itself is in red, and the yellow is the post-treatment. So the red is pre, the yellow is post. And you can appreciate that the access cavity is consistent with the conservative or the constricted endodontic cavity that's very much in vogue at the moment. So in terms of where things are going with minimally invasive dentistry, the focus is highlighting the preservation of natural tissues. So that requires it basically is essentially an intersection of specific benefits that outweigh potential risk. So you're looking at, in a sense, it's procedure-driven, but in fact, it is patient-centric. Preservation of tooth structure as it pertains to the possibility of fracture, of the crown being dislodged or debonding, if you will. And it is also, the situation here is that it's a component of skill of the clinician. But all of that is integrated because in truth, we are a restoratively driven profession or discipline at the moment. So what you are looking at here is some work that was done by Gianluca Platino and Nicholas Grand. If you follow through A to F, what you're going to see is C.
It's not this one.
Next one, sorry. Okay. So what you're looking at is cone beam three-dimensional reconstructions and segmentations of lower molars that were prepared with different access cavity designs. So A through C is sagittal, D through F is axial. So A is the traditional access cavity, and you can appreciate, if you look down at the coronal, at the floor of the chamber, you can appreciate the imposition that is being caused with the pericervical dentin. And the mere fact that there's a divergence with respect to the access cavity preparation suggests that the tooth itself is increasingly at risk of fracture because not only being brittle, but there's relatively little in the way of supporting structure. The B and E is the conservative access. So you can see, again, there's been preservation of the natural floor of the chamber. You're not removing any of the axial wall structure. You're simply accessing through the occlusal surface and directing yourself in almost a convergent, or what Michael Trudeau, I think, calls a frustrum. You're converging in such a way that even though you're coming through a smaller access, you're still having access to the orifices without removing any of the axial wall to necessitate it. In regard to C and F, this is ninja or ultra-conservative. And again, these are all segmented, but in essence, if you were the clinician looking down on an axial view, there's no question that it requires a highly skilled individual to work through a ninja access, which increasingly, from my perspective, needs to be rethought of as an orifice-driven. I don't think it's necessary to simply do the one hole, because if you're disrupting the interface, then a second hole to go after the palatal or the distal buccal is not an issue.
Okay, there's people coming.
Hey.
They're going from the back. We have
Come on in.
Yes.
We're having a regular party here. I don't know, it's a watch party, just there's no booze.
Remember, we're live.
All right, and we're live, so we're not going to do anything silly or say anything silly, are we? So the next slide, please.
Yes.
Okay, so you are looking at where access trends are going. This is a recent publication by Neela Kantan and Kant, which is showing basically an orifice-directed access preparation. If you look at the histology, A and B shows traditional and a directed access cavity, the difference, okay, between the two. And if you're looking at C, it is the junction of the floor and the walls, and the junction of the floor and the isthmus between the two canals, which is what you're seeing in D. So in essence, if you look at this regarding where the arrows are, you can see that there's a minimal exposure of the floor, but you are able to remove the detritus that is present within the pulp chamber itself, irrespective of whether it's orifice-driven, which seems to be causing people a lot of stress. Not necessarily a concern in the contemporary today, simply because you were able to visualize so acutely. This was an example of an access that was done by a gentleman named Maxim Belograd, who was very much into restorative reconstruction of endodontically treated teeth. Two considerations here. If there's a crown in this particular tooth, if you listen to fellows like Paul Abbott, who I have the highest respect for because I've never seen anybody publish at that rate, his perspective on regard to retreatment or even just doing root canal is to take out the restoration, take out the crown. You have no way of knowing what the contamination is underneath the filling or the full coverage restoration, and for that matter, you have no idea if there's marginal fit. You're simply looking at x-rays. So the other person who's very much involved in this is Dr. David Clark, and for those of you who haven't read his work, in regard to restoring endodontically treated teeth, taking maximum advantage of enamel bonding, C factors, his infinity preparations, calla lily, I do not believe that it is necessary to go to an indirect restoration for endodontically treated teeth. If you follow David Clark's, that's it. Yeah, we're good. Okay. So the next slide. is a three-dimensional volumetric representation of micro-CT data, which shows the determination of the angle of curvature in each of the views. So A is minimally invasive, B is straight line furcation, and C is straight line radicular. So appreciate if you look at the residual amount of tooth structure that remains. In C, it's dangerous. B, not so bad. A, it's ideal. And so where the problem comes in is the angle at the interface of the root itself and where the penetration, where the access is gone. So the interface at approximately the middle third of the root changes. So obviously it was easier in the good old days when you had stainless steel files and nickel titanium files that hadn't gone into M-wire and all these various configurations of the changes, martensite, austenite, heat treated, whatever it was. But the reality is today, with all of the file systems that are available, and certainly my personal favorite, either the Edge Endo, the taper, the Sapphire, or the SS White V2H taper, they're flexible enough that this isn't really a concern. You don't have to be concerned with Scout files and glide path that you're going to have a risk. Far different than the era of somewhat stiff 06 taper files, which were in essence quite dangerous. The next slide is an example of the magical. You have to do it again, I think. One more time. Click it.
Back?
No, forward. Just you'll get
Okay.
the magic of the MB2, which should come up as fireworks, but isn't. There we go. Okay, all good. So two things with regard to finding the floor and dealing with it. Marguerite taught me the most effective thing I've ever learned, and that was to sandblast the floor when you were looking for orifices. Sandblast, it satinizes the floor, becomes very easier to look at the topography and the chromatic changes, and a drop of alcohol is highly effective in getting better visual acuity. So one of the things that I think a lot of people do is they leave a lot of debris in the canal. They don't clean it out, and they go hunting for canals at that point with an Endo Explorer. But it's illogical because it's like trying to look through something where you've got Vaseline over your lens. You get rid of it, and the sandblasting with aluminum oxide is ideal. So the next, we go back one and go ahead. For some reason it isn't showing, but that's okay. It was basically a table of authors and the various studies that have been done up until 2019 on the presence of things like the MB2 and maxillary first molars, which accounts for about 92% of cases. Third canals in upper premolars, about 5 to 10%. And here's where it gets very interesting. Fernandez and his group looked at middle mesial canals and mandibular molars, and they found 7.7%. But Ibert in 2018, and Borghese, they found, in terms of middle mesial, Borghese found close to almost 46%. So the reality is, the more we're seeing work from Versiani and from Guerrero, we're beginning to appreciate that the incidence of these aberrant, or what we perceived of as non-existent canals, they're there, and you have to find them. And I'll talk about Navident in a moment, but I'm convinced that Navident is not the future, it's the present, because dynamic navigation, given that you're mapping the patient's jaw onto a CBCT data set, and you're actually using real-time navigation to use the axial slices to find these canals, I suspect that increasingly, whether the incidence goes up beyond the expectation, if you're looking at teeth that are being analyzed by slicing or by reconstruction of micro CTs, I think you're going to find that the new technology, not static, but certainly dynamic navigation, will present you with the ability to see these unusual, they're not unusual, they exist. Well, they were perceived of as unusual by us in the past decade or so. Okay, so we can go to the next slide. And this is that was the one that we should have seen. That's okay, it went backwards, it's all good. Okay, so this is an animation that should work.
Let me see.
There you go.
There it goes.
See, this is what happens when you transfer Keynote to PowerPoint.
Nothing happens.
And nothing's happening.
Yeah, it doesn't. Nope.
I have to use Keynote, but this doesn't allow for it. Okay, no worries. And this is the next slide is an example of what the current access trends look like. Some of this has come off Instagram, Viraj Vora, others. Some of these come from William Nudera and other people who are very much in the mainstream in terms of these particular approaches. You can see on the right the truss, what they're calling a truss access. This is orifice-directed access cavity preparations, where you do not take out the central bar between the two, between the mesial root and the distal root. So in theory, just like a truss when you're doing a building, it supports the structure. The others are examples. If you look at the middle upper molar, you can see where the conservative endodontic access preparation was done. Okay, and as was described previously, the PCD is completely untouched because the access preparation doesn't go anywhere near it. And the one on the left is, again, a truss. Interestingly enough, filled with amalgam, which, weird as it may sound, is returning into vogue, especially as it relates to endodontics, because in theory, composite resins are intriguingly, they don't last for 30 years. Amalgams seem to. And in this particular case, the tooth is going to be crowned, full coverage. And so it seems to be that with the amalgam in place, you can find the margin easier, you can position yourself beneath the margin more accurately than you sometimes can with composite. And they're even getting to the point now where amalgam cores can be prepped on rather than worrying about removing so much tooth structure with crown lengthening. The other thing that's interesting is that if you want to look at this from the next slide, please. If you want to look at this from a standpoint of the laws of physics, if you hit a tooth on the side, you get scrambled eggs, or if you're a millennial, you get an egg white omelet. With regard to the compressive force, if you're stepping on the poles of a tooth, you can literally put a force of 100 pounds and compress it, it won't crack. If you put a pinhole in the top, it shatters. So I don't know that it's totally analogous to a crown, but it's not really that different if you look at the way the peritubular dentin is directed. So in theory, it's much the same. The greater the amount or volume of tooth structure that you remove when you're doing access cavity preparation, the higher the risk. Granted, retaining pericervical dentin makes all the difference in the world, but again, weakening residual tooth structure is a concern. Now that's not to suggest that the teeth that you're treating are completely intact and you're not worried about removing natural tooth structure. But again, it goes back to Paul Abbott. Get rid of everything that's in the tooth, be it a crown or whatever, unless of course it's part of a long span bridge, and unless you're doing root canal and an implant, for example, which is unlikely. So again, you're looking at specifically at retaining as much as possible. That's orifice-driven or restoratively driven endodontic access. And the next slide is the integration of, in this particular case, Navident and microscopes. This is a dynamic duo, if you'll pardon the pun. It is different for most endodontists to realize they have to look up to follow the monitor to look at where it is that they're dynamically navigating the burr with respect to where it's going into the tooth. It is for access purposes. It is much easier to do, much more accurate than doing this through a microscope. The entirely minimally invasive aspect of doing dynamic navigation is dramatically different, if you will, than doing a sort of freehand navigation, in spite of whether or not you have a microscope. And the day will come probably where the CBCT will be superimposed perhaps on a smaller monitor that's attached to the scope, or there will be some way of placing the scope, or at least the target of the dynamic navigation, into the oculars. Nonetheless, this is going to very rapidly become standard of care. And it's interesting, minimally invasive endodontics is driving the need. We go to the next slide, and it is essentially there's going to be an infinity connection. These things will go hand in glove, as it were. Ergonomically, because of the size of Navident, it makes things so much easier. The microscope is able to illuminate, magnify, and allows you to freehand navigate, whereas with Navident, you trace, register, and navigate. You actually plan, is what I meant to say. And you're planning on the CBCT, you're directing and finding your angulation into the actual canal space. I'm not sure that this is, okay, yes it will. You're looking at, these were micro CTs that were done, I'm not sure what was in them, but regardless, it's a very effective way of demonstrating, once again, the difference in terms of traditional and conservative access cavity preparations. So you have to find the balance between structural failure, diseased dentin, and find out what you have to remove and what you have to preserve in order to ensure that you're not causing a problem. The other thing that's interesting is if you flip to the next sequence in this, Jorge. And there we go. This is, I believe, the work of Frank Paquet. And if you take a look, the green in this case being the natural canal and the red being the prepared canal. And if you take a look, in reality, maybe 45 to 50% of the contents of the root canal space are eliminated. So when you're looking at this from a standpoint of access, it's not so much access that causes the problem, it's just our inability to deal with a three-dimensional canal with literally a two-dimensional rotating file that has it's a round blank. So it's got a solid core. And this, if nothing else, is leading us to the gentle wave era, where if this is what we can achieve with our instrumentation, it's really irrelevant because gentle wave will ensure that whatever residual contents of the root canal space are present, they will be eliminated. Next one, please. So what you are looking at here is minimally invasive endodontics in terms of the biomechanics as it relates to the endodontically treated tooth. In the traditional endodontic cavity preparation, you remove the entire roof in order to get straight line access. The CEC, or the conservative, provides only curved pathways for the NiTi instruments, and as I indicated before, that's not a big issue. Their claim is that there is a risk of iatrogenesis. I don't believe that. If you look at recent work that was done by Dr. Freeman and others at the University of Toronto, and I think in Japan, if I'm not mistaken, that this isn't an issue. You will pick up most, if not all, of the canal consistent with what you may find in traditional. The only canal that seems to be somewhat difficult in the lower molar is the distal. But what you are looking at here is the way this statically loads and the position of the cuspal in mastication, where you are looking in centric occlusion. And one of the reasons I showed this in particular is I referenced David Clark in the past. And one of the things that he does that I find so fascinating is he's using composite. And in regard to how he's doing restoration, he's not worried about cuspal inclines, because cuspal inclines with any restoration are parafunctional. And with your occlusion, it changes. You'll get older, things are different, muscle strain, this sort of thing gets different. And the risk of high incline cusps are essentially that you'll either debond or fracture the porcelain or actually cause fracturing of the tooth. One of the things that Dr. Clark does that I find so fascinating is he just obviates the need for it. You're looking at a functional tooth that can be aesthetic, regardless, because the composite can be beautifully polished. So again, you're not only looking at restorative directed endodontics or orifice directed, you're now looking at restorative directed in terms of reconstructing the occlusal table in such a way that you're dealing with contractive forces in terms of mastication, and that's sort of a big change. The other thing of interest here, this was a Journal of Dental Research study by Estefan, okay, is the presence of an isthmus. Again, this is sort of what drives me back to gentle wave, because the more, for example, that's a 2508, not sure if it's reciproc, but again, don't quote me. But again, when you're dealing with danger zones, this business of 06 tapers are illogical. 04 at the most, but you do have to get the isthmus out because the prevalence and the location varies. And in this particular case, it was done, I forget which population it was done, but it can begin apically and then migrate upwards, and they determine the number of different classifications. So even if you can do the best possible access, it is still going to boil down to the irrigation and the removal. But it doesn't preclude the need to go to traditional. You're fine just doing conservative to meet your objectives. And similarly here, this is one of the reasons why, again, I've gotten seriously involved with dynamic navigation. This is an example of a middle mesial, and the further you go down the axial slices, you can see the danger that begins to arise in the concavity on the distal aspect of the mesial root. Distal root is seemingly fine. There are certainly, when there are two canals, there certainly is a concavity, but the concavity in the mesial root is extremely dangerous. And given that you're dealing with this isthmus, you can over-instrument, but you still have to find a means of properly irrigating. So access in this particular case, you would avoid being aggressive. It's another reason for dynamic navigation, and it's also a reason for things like the endovac and gentle wave. So these are the access trends that you're looking at. As I indicated, it was orifice directed. You can see how small those preparations are. And the one on the upper right is totally orifice directed that was done with Navident. The one on the lower left, again, orifice directed, highly indicative of the preservation of tooth structure. No reason to remove the roof, if you will, of the chamber. It makes no sense if you can get into the root canal space. And really, with all of the irrigation devices that we have, it's not really an issue about debriding and cleaning out the chamber space. Another example of angulation, and the point of repeating this is basically you can begin to justify the fact that with the current era of nickel titanium files, for example, the XP3D, which I happen to like, which allows the tooth to shape the file, not the other way around. Be it Ninja, be it conservative, you'll still find that with the nature of the files that we have currently, you're quite able to get around the curvature. Little more difficult if you look at A, but staying conservative, it's quite comfortable. There's no real iatrogenic risk. Similarly, with incisors, both upper and lower, in some cases they used to recommend labial access in lower incisors. Not really necessary, certainly not with axial cuts, and certainly not with axial slices rather, and certainly not with the ability to irrigate as indicated. This, from my standpoint, lower incisors, again, this is a very strong indication for the use of dynamic navigation. 50-odd% have 2 canals, otherwise there's an isthmus. So I think it is completely important to really look at these teeth from a different perspective. For all intents and purposes, this is the mesial buccal root of an upper first molar. All of the Vertucci classifications apply. And the biggest problem here is ledging if you miss the lingual. One of the reasons, again, for dynamic navigation is that if it's been treated, then it's very hard sometimes to find the missed canal, especially if it's been sort of ledged, whatever, in the chamber by the previous operator. So the need to go to a more direct and more accurate access, especially not doing it in the area of the cingulum, is that you the instruments don't bind coronally, which is the key, which tends to kick them into the facial canal space. And again, the concern here is that you've got a very small access space and therefore difficult to irrigate. And by doing this, it allows the needle to actually get deeper into the canal space. If you're just coming from the lingual, traditionally, you're going around curves that don't need to exist, and that's an issue. Now, if we go on to the next one, okay, we're reinforcing all of what we've just discussed in regard to the picture on the left. Okay, look at the other images, look at the amount of the tooth structure that was removed, look at the case on the left, which I think was done by William Nudera. First of all, I apologize if I'm not referencing people. I will at the end, all these people that have contributed from online and actually from providing the information. So the take-home message will be more dramatic. But look at the size of the access. Preservation of the PCD looks very much like the picture on the right. But again, in this particular case, I believe he uses gentle wave, and I think that's, again, the direction we're all going to go. This is an interesting, next one, please. Jorge, the next slide. Thank you. Okay, so one of the reasons for, I don't think you can do endodontics without CBCT. I don't think it matters. There's these criteria. You can't do it if too much radiation. That's not really true. The number of sieverts from a small field of view 4x4 CBCT are somewhat equivalent, I guess, to 3, 4, 5 periapicals. What was fascinating about Dr. Gavino's, this was an 8100 Carestream, is the fact that he found 3 such perfectly identified canals in the mesiobuccal root of the molar. So how can you do root canal without a CBCT? So if you look at the one on the left, they're looking at different radicular and coronal findings. There's apical periodontitis, and invariably the number of people who were looking at these particular slides, there was a difference in their perception of whether something existed or didn't exist. You can see that 81% said no, the other 19% said yes. Well, two-dimensional, we're not three-dimensional, two-dimensional rather, individuals, we're three-dimensional, and therefore I think the CBCT for any access is essential. I believe this is some work done by Dr. Yossi Namias, and once again, through a crayon, somewhat, next slide please, sorry. I keep forgetting to tell you. Beautiful examples of mesiobuccal, mesiolingual, or MB1, MB2 in mesiobuccal roots. And again, terrific examples of the complexity of the root canal system and yet conservative access. So we're going to sort of finish up in terms of the future direction, what we are starting to see in terms of the next slide, Jorge.
Yep.
We're looking at middle mesial canals, which are now popping up like, June is busting out all over. And it's increasingly being able to be found. As I indicated before, I forget who it was, Ferguson, I believe. The incidence of these is occurring in as much as almost 50% of cases. And this was the final canal. Sorry, next slide, please. This was the final configuration of the mesial route and the distal route. The 5 canals, which increasingly is more and more evident. Okay. So if we go to the next slide, it's probably a video that may not play because I transferred some key. It should. Okay, well, I apologize. So the next 2 slides probably won't play. All right, that's not good. We'll have to transfer them in a different way. This was a case from Dr. Chaniotis, and it was demonstrating how the high flex file would basically not be concerned in this case by the conservative or almost, well, it's not ninja, it's conservative, okay? So if we go to the next one, this is a case of Dr. Nudera, where again, orifice-directed access to treat at least 30% have second canals. And if you look at the work that's being done by Diego Guerrera, who's fascinated with lower bicuspids, the unusual anatomy of lower bicuspid is extraordinary. But here's a good example of what you were able to do with directed access. In this particular case, it was not dynamic, but nonetheless, Dr. Nudera is quite dynamic. And the other reason, next slide, please. No, I think one back, okay? So again, CBC is invaluable. You can see the internal resorption, external resorption on the molar. And so once again, you were dealing with a situation where accuracy is paramount. So there's a balance going on today with microscopes, dynamic navigation, but it's not a balance. They're actually a duality. And in cases like this, where external cervical resorptions are increasingly more prominent, something that needs to be addressed. In regard to the next slide is, where am I? Okay, reiterating again the orifice directed and the end result here. We're increasingly seeing smaller canal sizing, which is fine, Nobody said that you had to impose an 0.6 taper on a canal space. And the statistics, if with rotation of calcium hydroxide, if you look at the work that's been done by the TDO group, size of the files doesn't make a difference. You're still getting healing. And increasingly, as I said with GentleWave, it's going to be a non-issue. So all of these are going to line up. Dynamic navigation, minimal access, the accuracy of identifying the orifices, orifice-directed access, and changes in irrigation protocols, which in this case I suspect will end up being GentleWave. This was a slide that Dr. Nudera gave me, and I thought it was fascinating as a teaching slide. Next one, Jorge, please. Okay. So this actually comes, originally, the first time I ever saw something like this was Dr. John McSpadden in his incredible textbook called Mastering Instrumentation. So he was able to calibrate based on taper and curvature how far down you could go with specific file sizes. And this was how Dr. Nudera charted out a very unusual root canal system. And this is how we treated it, segmentally. It's like we want to get to the apex. We want to get our 15 file to the apex, and the answer to that is no, you don't. You want to get where the file is going to go, and you want to be able to appreciate where the curvature initiates. And you treat root canals segmentally. So you want to be able to target as far down the canal as you can in regard to identifying it. Straight line access, no, but being able to negotiate it with a scout file, yes, as far down as you can get it. Or a glide path file, whatever it's going to be to get this thing started. Once again, the advantage of dynamic navigation. The other thing I want to talk about very briefly is rubber demology. Can we go 2 slides ahead, Jorge?
Okay.
Because this is the one, this is by Callan Popp. And if you've never seen his particular, he has an incredible series on rubber dam isolation, be it applied to aesthetics, but as it applies through root canal, it's extraordinary. It's not quite clampless, but it involves placing canals in less injurious ways and then using floss as your clamp. I don't remember the name of the website, but his name is Callan Popp. he's on Facebook. It very much warrants your attention. As you can see in this particular case, he uses Teflon tape and dental floss to retract the rubber dam down around the tissue to hold it in place. And you can see the preparation. By doing that, he's not getting the rubber dam coming up over the margins. In this case, when he was doing a preparation for an inlay onlay, which almost looks like a David Clark composite resin inlay onlay. Unfortunately, the video that I have of his obviously won't play because PowerPoint doesn't like Keynote. And so again, with regard to isolation, yeah, it's such a beautiful, whatever. Life goes on. We all make mistakes. So the one thing here, you'll notice the Aura seal on the other side. It's opal dam that should be used, which is what you're seeing around the upper molars there prior to whitening. I didn't have one of a lower molar, but it's opal dam by UPI, okay, highly effective. So we're going to go on now and look one more time at chromatic topography, where we look at the etcher. Okay, you can see the difference in the two slides when you clean them up. And there's another factor in all of this. The MB2 was missed, yet you can see how the sealer in the next slide came squirting through off the primary canal. So I'm not sure whether this could be something that anybody would have picked up. It seems to be, that's where it should have been. Sealer came up and out, but again, it's not often that you don't, that you can't find it. I mean, there's obviously cases where they exist and you can't. But I think increasingly, I keep referencing GentleWave, the stuff that has shown up with GentleWave, or even if the canal is not identified, the actual the acoustic technology, the sound technology will allow these things to appear. And lastly, we are getting to the design, looking for MB2s. The next one is the Zorro preparation, as you can see, by moving the wall away. Similarly, the case such as this, if you go to the next one, the difference in terms of, this is by Dr. Minor Haas, where you can identify it. And if you go on, you will see it. Okay? And its particular orientation in terms of the line between the MB1 and the palatal. And lastly, this beautiful case that he did, if you show the X-ray. Okay? Now, if you go to the next one after this, this is another reason why I'm not so sure that freehand navigation is the way to go. The arrow was pointing to the damage that was done to the PCD. And so all of these things, once again, are reinforcing the concepts that are required. Actually, to use caries detection agents is a very big help as well. And go to the next one, if you will. Okay, so it gets cleaned up nicely. Again, all of the things we talked about, alcohol to visualize, sandblasting. If you go to the next one, please. So I'm not a fan, I don't like ultrasonics. Certainly not the jackhammers to the left, the smaller ones. The ball, I like, because it's very effective for taking out posts and large pulp stones. Preference is the C.J. Muntz Engineering Discovery burrs and anything, even slow speed round burrs. Preferably the EndoGuide Access burrs, the anterior and posterior burrs by Clark and Cotomy. But I really think we've reached the time when staying away from ultrasonics is the way to go. It is truly a jackhammer. And I don't know, I think it obscures the orifice much more so than it does accessing or visualizing it. And if you go to the next slide, it was also done by Dr. Cotomy ages and ages ago. I don't remember how old this came up on Roots, but you can see how I think these were, what was it called? Buchanan tips. And you can see how removing the pulp stone is readily done by not drilling it out, but by using ultrasonics to do it. Prevalence of pulp stones, interesting enough, in maxillary first molars, restored and or carious was as high as 50%. Those that were unrestored and patients were aging is 30%. And so ultimately, as patients are getting older, I think this is going to become an increasingly more and more important issue. Dr. Namias shared this. The next one. The chalky pinhole. Yeah, we'll be good. Chalky pinhole, as you can see. All right. Another reason for sandblasting. Another reason for alcohol. And if you look carefully on the one on the right, you can actually see the communication of the isthmus up into the coronal third of the canal space, and the fact that there is a middle mesial canal, and it's self-evident. I was addressing caries detection. If you go to the next one, please. All right, this is what you find. You have to find the tertiary dentin with caries detection. It's quite effective. And I'll harp back to dynamic navigation. You would not need to do this if you were actually targeting the canal space with dynamic navigation and finding it irrespective of whatever the depth is. Because you're using the axial slice and you're actually monitoring and tracking in real time, you would have no difficulty finding your way into the canal. And as we approach the end, that's the difference in terms of what you were able to find. Okay? Without removing any excess, because they did the caries detection agent in this case, the canal that wasn't off-angled in any way. My point being that you can see, though, where the actual restoration is, of a temporary restoration. There was sort of a chase down through the chamber. Again, one of the reasons why I think dynamic navigation is going to change endodontics. There's also, again, Dr. Namias points out what they call the starfish. If you go to the next slide. So the starfish pretty much tells you where the canal was and where it used to be. And the next slide will show, again, we're going back to middle mesials because I wanted to leave on that note. So you've looked at all of these various configurations, upper molars, lower molars, bicuspids, calcified canals, this, that, and the other. Unfortunately, the take-home message is we are living in the cone beam tomography era. That's where we are. And we have to accept the fact that the days of old freehand are starting to fade. Our ability to use finer and more restricted and more minimally invasive instruments will be heightened. More and more of them will be invented. And invariably, we are going to be, what's the word I'm looking for, pseudo-robotic in terms of our approach to doing root canal therapy. With that, I want to thank Jorge, the folks in the room. Thank you for coming. And thank you for doing this, and thank you for participating and listening. And you all have a nice day now, okay? Thank you.